helpline. Now, I've got 2 asks of you today in terms of trying to create 2 mini videos that I can create. One of them we've actually covered recently, but I would like to just cover it again because we are seeing it coming up, which is the concerns around OCA and the information that's been out about deaths that have happened and people worried about safety. So I'd like to do a little, maybe a 10-minute slot where I can capture that as a mini video and share if needed. And then also another sort of general one around high cholesterol and statins. But I've got some other questions that have come in too. Do you want to start with the OCA one for us?
Yes. So obeticholic acid has been in trial for 15 years, probably something like that. Time goes by, and it's been approved and has been used pretty much around the world for sort of 8 to 9 years, depending on the territory where you come from. It's pretty much universally used. I think our centre here has treated about 130 people now with it. So there is a lot of experience using it around the world. Okay. I think it's now up to something like 10,000 patient years. So, you know, 1 patient for 1 year is 1 patient year. So you can get some sense of the experience that comes with it. Okay. Now, everyone who's had OCA has been followed up. So information is collected on everybody. We do it for the UK through UK PBC. And that's part of responsible understanding of drugs. So information is routinely collected to identify patterns. And people will be familiar with the tragedy around thalidomide in the 1960s. And that led to this post-marketing surveillance approach. So you don't just approve a drug and then sell it. You have to see what happens, because the problems with thalidomide were only picked up after it had been licensed. So it's a very established thing around the world. The experience of people who've used OCA around the world, including ourselves, has been very good indeed. We have seen no problems with it at all in any of our patients, and the UK has not seen any problems. Now, the people who have PBC still have PBC. It doesn't cure the disease, and so it's an important condition. That's why you're treating it. And so things will happen to people with PBC who receive a drug, and they'll happen to people with PBC who don't receive a drug. And it's important to realize that, because you're trying to understand, is there any issue with the drug, or is it part of the disease, if you like? So the view, and all hepatologists will tell you, that we spend our life worrying about whether drugs cause injury to the liver, not drugs we use to treat liver disease, but liver in general. There are lots of drugs that can cause problems. An example is flucloxacillin, an antibiotic that many people have had. Millions of prescriptions a year, but it can cause a disease not unlike PBC. Does that mean you shouldn't use flucloxacillin? No, it means you should be aware of it and think about it and do it. So we're all familiar with drugs that cause problems, and we're also familiar with drugs that don't cause problems. And the honest view of the clinicians who use obeticholic acid, certainly in the UK and in Europe, is that this is a drug that doesn't really cause any problems. Now, it does do 2 things, but it doesn't tend to do that for us, because we're careful about what we do. So the 2 things it can do is that it can cause itch or make itch worse, usually early within the first 3 months. Okay. So this wasn't expected when we did the trials. I think we described in Newcastle, we had the first person who got the itch. And so we were kind of responsible for that. And it definitely happens. It does not happen in anywhere near, you know, it's a tiny minority of people in practice, but it does happen. What that means in practice is that we would tend to avoid obeticholic acid in people who've got itch, particularly if it's problematic, particularly now that we've got alternative therapies like elafibranor, shortly seladelpar, also bezafibrate. So we would choose which second-line therapy to think about based on the amount of itch that people have. And that has basically made the problem go away. I mean, we haven't had problems with anybody getting itch with obeticholic acid for a while. And it's what you've heard me say many times in these sessions. It's good to have choices available. It's good to have lots of drugs so that we can find a drug that is the right one for you. If you've only got one drug, it's more difficult. So Itch, it is there. It will be an issue. The vast majority of people with itch with PVC have never taken obeticholic acid. The vast majority of people who take obeticholic acid don't get itch, but you will see more. Okay, so that's problem number one. Problem number two is one that was seen very early, indeed, which is in some people with PVC, it made their disease worse. Okay, now all the trials show that it makes people's liver disease better in terms of the blood tests and things we follow, but in a small number of people, a tiny number of people, it made their disease worse. Okay, and these were people with pretty advanced cirrhosis. Okay, now the problem when you have cirrhosis is that your body has coped with losing a lot of your liver function, and your body does what we call compensate. So you lose up to half of your liver function without it causing you any problems, but you've lost reserve. So you've lost the spare capacity. It's a bit like spending your savings. You know, you've still got enough money in your checking account, but you haven't got any spare. So you lose liver function, and so people are a bit more vulnerable to ups and downs. And if you get to the point where there isn't enough functioning liver, then you'll go into, you know, what we call decompensation. You see the complications, and it is very clear that obeticholic acid can decompensate people with cirrhosis, which is on the edge. Okay, now 95% of people who receive OCA do not have cirrhosis. The whole point of OCA is to stop people developing cirrhosis. In fact, we tend not to treat people with cirrhosis because it's not going to really help people. So this is not an issue for the vast majority of people because they don't have cirrhosis. That's the whole point of what people are doing. Now, I do see we have a friend from Michigan, so please excuse me, but I'm going to say a terrible thing, which is this problem exclusively arose in America, okay? And it's because of the way in which drugs are prescribed. So the drugs are prescribable by anybody in America, I mean, any doctor, whereas in the UK, we're highly restricted. Only about 30 people in the UK can prescribe obeticholic. I can't prescribe it. I have to ask permission of one of my colleagues. Can you imagine what I feel like with that? So we have a very tightly controlled system just to make sure you're not making the wrong decision for people. And we've not seen these problems. In America, where family doctors, office doctors could prescribe it, there were people who were frankly needed transplant, got the drug. And that's where the problem arose. Now, that's nothing unique to PVC. It's not unique to obeticholic acid. There are lots of diseases where a drug will push you over the edge. Steroids will do it with autoimmune hepatitis. So it just tells us that we should just avoid developing cirrhosis in the first place. The whole goal of treatment is to stop people developing cirrhosis, because once you've got cirrhosis, it becomes more complicated. And that in a nutshell is everything we're trying to do in PVC at the moment. 10 to 20 years ago, the art of hepatology was to spot the complications of cirrhosis and manage those. We've shunted the whole thing a stage earlier, and it's about preventing cirrhosis. And practice in the UK has been essentially to treat non-cirrhotic people, and we've not seen any of these problems. By the way, I think exactly the same thing will happen with elafibranor and seladelpar. It's nothing to do with obeticholic acid. It is to do with the fact that if you haven't got much liver left, these drugs will behave in an unpredictable way. Now, so on, that was what we knew from a while ago. The prescribing information to stop it being prescribed in cirrhosis was there. It was still being used occasionally in America, and problems are still being seen. But that's an education thing. And then the latest guidance is about concern that it can cause liver injury in people who don't have cirrhosis. Okay, and that's what the concern that was issued before Christmas is about. And I'll be frank, I do not believe it. Okay, and you know, I am somebody who has the utmost concern for the interests of patients. And more to the point, none of my colleagues who manage PVC patients believe it either. Okay, now, when you go into the data, it was based on a very, very small number of cases. So we're talking about half a dozen cases worldwide. And when you look at those cases, as I have done, they are people who in fact have got cirrhosis. It just wasn't recognized. And that tells you something. So just because you haven't been told you've got cirrhosis doesn't mean you have it. But this is why we fibroscan people. This is why, if necessary, we do an endoscopy to look for varices. So these were people who actually had cirrhosis. So they shouldn't, at the time they got OCA, got it, but they were labelled as not cirrhotic. So, you know, it isn't what's in the notes, it's what's really happening. And just to tell everybody how absurd this is, one of the people, so much has been made of a poor lady who needed a liver transplant shortly after starting obeticholic acid, who definitely didn't have cirrhosis, okay? And the regulators are making a big thing about this. This person took obeticholic acid, and within literally a matter of weeks, they needed a liver transplant. I think we would all agree that's terrible. However, the reality is she was on the elective transplant list for itch, okay? And she had her transplant, her organ came up shortly after she went on obeticholic acid. They were entirely unrelated. It was an elective transplant. Her liver function test hadn't changed at all. So that is people adding 2 and 2 together and making about 100. Yes, she was pre-cirrhotic. Yes, she took OCA. And yes, she had a liver transplant, but those were, the OCA was entirely unconnected. And you might want to step back and say, why in God's name did somebody get obeticholic acid in a trial when they were waiting for a liver transplant for itch? You may well ask that. I can't comment on it other than it's bonkers. So that's the problem, is that there's a lot being made of very little here, which has scared people. Mm-hmm. So what would I do? I think and I will add one thing, which is why, you know, why not use one of the other drugs, right? You know, if people are worried about this, no smoke without fire and all that sort of stuff, why not, you know, use one of the other drugs? Okay, well, there are 3 reasons. The first is we don't know how safe the other drugs are, okay? We didn't know any of these issues at the same point in their development. So just because problems haven't been seen when you've only seen it in practice for a very short period of time does not mean that they won't happen in different forms. So it's a bit of an, you know, simplistic way of looking, say there isn't a problem, and that's because they've not been used in practice, literally tiny numbers of people. You know, the total number of people who've had elafibranor in the UK is probably the number of people we would start on OCA in a month, right? You know, it's tiny numbers. So just because you don't know there's a problem, you know, doesn't mean there is a problem. So you are swapping something where you know a lot about it for something where you don't know anything about it, on the basis that because you don't know anything about it, there's nothing wrong with it. Well, you know, I don't think you would necessarily think that's very logical in other settings. That's the first. The second is that I think most of us believe that there are essentially 3 levels of effectiveness of treatment in PBC, and this is really important. So the first is URSO, okay, fine for many people. There are many people on this call whom that's fine, right? The second is any of the other drugs added to URSO, and it probably doesn't matter, bezafibrate or obeticholic acid or elafibranor or seladelpar. And people will say this is more effective than the other, but there's no evidence. They all work and they all probably roughly the same. So that's your second level. And then the third level, which would be for people who haven't had enough of a response to one of these drugs, is to use a combination. And the only combination we can use is obeticholic acid and bezafibrate, okay? There are no other combinations that people can use because of the cost of the drugs, okay? That may change in the future, but right now, if I want to give 3 drugs, it has to be URSO plus bezafibrate plus obeticholic acid. There is also nothing to be gained from adding bezafibrate to elafibranor or bezafibrate to seladelpar because they work in the same way. So the combination of treatment requires different modes of action, and the only way to have an additional mode of action beyond URSO and sort of elafibranor, seladelpar, bezafibrate is obeticholic acid because it's the only drug in that class. Now, if I was to say about of people who don't respond to URSO, probably about 10 to 20% of them, their blood tests will normalize with one other drug, about that sort of level, 10 to 20%. So you definitely see it, but it's not the majority of people. The combination of URSO plus OCA plus bezafibrate will give you 70 to 80% normalization. So we're not talking about tiny differences, we're talking about quite big differences, okay? Now, if you are a 20-year-old with an alkaline phosphatase of 1,000, a family history of PBC, you need really good control. And in that situation, the only thing that will give you really good control is that combination. So if we lose obeticholic acid, we lose the capacity to take this to the next level in those people who need it. And if we don't treat those people, they're the ones who'll need a transplant. So we will have other drugs, but we will lose the capacity to go to the next level, which is very important. And then the final reason why, we still need OCA is that there is no logic in stopping somebody who's been on a drug for 8 years, whose blood tests have normalized and who is tolerating it absolutely fine. There is no logic to swap that person onto an untried treatment for no reason. Okay, so we swap drugs all the time with people, but it's for a reason. It's because they've had a side effect or because it doesn't work. But this is people in offices who don't treat patients issuing diktats to change it. And that's actually wrong, because you lose the potential to control the disease, you potentially gain side effects, all because of very arcane views of, poor clinical practice, I'll be honest. And I think that's what a lot of us object to, is that we're all used to dealing with risk with drugs. We're big boys and girls. We do that all the time. And patients are remarkably sensible about this. And I think we're always lied to side effects. But this is about stopping us doing something that we routinely do, where we see literally no problems with it, but on the basis of evidence that we don't agree with. So in short, to that guidance before Christmas, it's cherry picking cases which tell a story, but that story is not correct, because the story, each of the individual cases, is explainable for a different reason. And in the 10,000 patient years of follow-up that the company have taken, we've never seen this. And certainly in the UK, we've never seen this. And so, it's I can't say never happens, but, there are probably 90% of the drugs I use in people with liver disease I've been more concerned about than with OCA. So what would I do if I was a patient now? Okay. So what would I do? So if I was just going on to second line therapy, okay, I think you pays your money and takes your choice. I think there's a good argument for, using one of the other drugs. There's no reason not to. Okay. So you might choose to go down that line. And certainly if you've got itch, there's lots of good reason to use one of the other drugs. Okay. If I had really bad liver blood tests, okay, and Urso wasn't touching it, and I and my clinician felt I was likely to need a combination therapy, then I would go on to obeticholic acid and then add in bezafibrate. And in truth, we often start triple therapy. If you've got itch, we would start the bezafibrate first and then add in obeticholic acid, because I wouldn't want to lose the opportunity to have obeticholic acid with combination therapy. Okay. Mm-hmm. If I was already on obeticholic acid and I'd had a good response to it and I hadn't had any problems with it, I would simply continue with it. Okay. And I absolutely would not. And we are not changing people over. If any patient came to us and said they were worried about it, then we would happily change them to another drug. Of course we would. But nobody has done that in our clinical service. Nobody has done that. And we, at the moment, based on what we know, wouldn't go to change it. So I think there's a lot of protecting of positions. There's a lot of doubling down on all of this. And I think it's unhelpful for patients. And it has the potential to unravel enormous progress. So in short, the answer is move along. Nothing much to see here. But we are live to it. Of course we are.
No, thank you. I appreciate that. I know we have talked about it a few times over the last, probably since the turn of the year. We've had a couple of chats about it, but I wanted to make just a little video that we could have on standby for people, because we are still seeing concerns getting raised.
Yes.